Now I would like to invite Dr. Girija for a presentation on post-operative glaucoma.
Good evening, everyone. Post-operative glaucomas. So these are very complicated because they are actually refractory to the conventional treatment and they are very aggressive in nature, and also because of the repeated surgical procedures there will be conjunctival scarring which affects the outcome of the filtering surgery, and also the final visual outcome is also not good because of the coexisting retinal and optic nerve pathologies. So the causes, any ocular surgery can cause secondary glaucoma. I'll be dealing only with the common ones. The post-PKP glaucomas, usually 9 to 50% incidence has been reported, and it's more in case of when the PKP is done for infections like herpes virus infection, trauma, or regrafting. And it is difficult to diagnose because the tonometry itself is difficult in an irregular cornea. Sometimes it may be highly astigmatic. In the pre-op diagnosis is difficult, and even the post-op. Because of tonometry difficulties, and also to see the fundus also, it's with the hazy media, always prevents the proper visualization. But it's always better if you can diagnose the pre-op glaucoma. And GAT still remains the gold standard here. It underestimates the IOP in ectatic diseases, but no substitute has been found out. And the Pascal DCT is independent of corneal astigmatism and CCT, and it can be used if available, but again it overestimates IOP at higher values and underestimates at low values. The postoperative glaucomas in PK, it can be either an early onset glaucoma or a late onset glaucoma. Early onset, as you know, the high viscosity viscoelastics which are used to protect the corneal endothelium, if they are not properly washed, then they can lead to an early onset glaucoma. Then PK itself can cause tissue deformation, and it can promote inflammation and disruption of the blood aqueous barrier, and there may be clumps of inflammatory cells and serum components which can clog the trabecular meshwork. And fibrin-rich exudates, if present in the anterior chamber, can result in synechiae formation, both pars and posterior synechiae, and thus resulting in a pupillary block. Suturing techniques and transplant size is also very important. Either a same size donor button, long tight sutures can compress the iridocorneal angle, and it can result in a secondary glaucoma. This patient was operated for bilateral macular dystrophy. Left eye was operated, the left eye cornea was very hazy, so we couldn't see the fundus, and the IOP also could not be measured preoperatively. She underwent an optical KP, and she was on postoperative steroids. But the IOP started rising postoperatively, and 3 months later the IOP was found to be, with 3 drugs it was 34, and with 3 drugs we could reduce it to 20, and then later we couldn't taper the steroids actually. Then after 15 months the sutures were removed and the IOP came down, and we could reduce the anti-glaucoma medications. So the tight sutures, once removed, reduce the glaucoma. So proper surgical technique is very important. Less tight sutures, deep sutures, short ones with equal length on either side, and slightly larger donor graft. These can prevent ankle compression. Now, corticosteroids are essential to prevent the endothelial rejection and also to maintain the graft survival. But they can, as Dr. Smita has already mentioned, the steroid response is very high after a PK because they require long-term steroid treatment, even more than 1 year, and very OD dosage usually is given lifelong. So, corticosteroid response can result in secondary glaucoma. And the steroids, there are various mechanisms, and also there will be persistent inflammation, late onset, which can result in pars formation and glaucoma, which is difficult to manage medically. DMEC and DSEC are becoming more and more popular now, and there is an early onset glaucoma due to the air bubble that you inject for the attachment of the graft. If you inject a very large air bubble, that will produce, the aqueous cannot, it will fill the anterior chamber and the aqueous cannot flow into the anterior chamber. So a prophylactic inferior PI is always recommended, and so that the aqueous can flow through that into the anterior chamber. But if it is filled 100%, then there won't be any space. So it's always slightly underfill the anterior chamber. Then only aqueous can flow and there won't be, the glaucoma can resolve as the air bubble absorbs. And the incomplete removal of the viscoelastic, prolonged steroid usage, especially in DSEC, can lead to glaucoma. So the prevention management is always diagnose a pre-op glaucoma, and prevention can be by proper surgical techniques, a donor graft and also the suture techniques, and always do a prophylactic inferior PI. Topical steroids, they reduce the risk of PS and PAS formation and pupillary block, but they should be carefully monitored, tapered and substituted. Local topical AGM should be given, and PGAs are better avoided in the early postoperative period. SLT is also showing promising results. Surgically, if the IOP is not controlled medically, then you can go for trabeculectomy, which has longer periods of graft survival when compared to AGV, but mostly GDDs have to be done for better control of IOP, and the tubes have to be placed. If it is a pseudophakic eye, it's easier to place it in the sulcus, because in the anterior chamber it can lead to again endothelial cell decompensation. Post retina surgery glaucomas, all the retina surgeries any retina surgery in fact can cause a secondary glaucoma. It can be either a PPV. Usually in PPV there is gas expansion, there can be with or without. You can get open angle as well as angle closure glaucoma caused by the gas expansion, inflammation, ciliary oil, the silicon oil, and then there is the corticosteroid response and the blood mediated mechanisms. So combined procedures have a more chance of producing secondary glaucomas, especially if it is for PDR, and then pseudophakic and aphakic eyes have more incidence of glaucoma because lens has a protective role. Scleral buckling can cause an angle closure glaucoma, especially in previously narrow eyes. And the encircling band, which especially if it's placed anterior to the equator, and it can actually impair the venous drainage from the vortex veins and can lead to swelling of the ciliary body. Again, the non-pupillary block glaucoma can be caused. And open angle glaucoma also can occur in scleral buckling. Then silicon oil, as you know, silicon oil can emulsify and it can block the trabecular meshwork. And this is also more in case of, it can also cause a pupillary block in aphakic patients. And again here also early and late onset glaucomas are seen. Intravitreal gases like C3F8, SF6, etc. can expand. They will expand and they can increase the IOP initially by open angle mechanism. Later on, by pushing the lens iris diaphragm anteriorly, it can cause a pupillary block glaucoma. And when there is intravitreal gases, always measure the IOP with a GAT, because if you do a usually other methods of tonometry may not be correct because the gases are compressible. And patient should be always properly educated. The importance of maintaining a prone position and also to avoid the air travel. And the glaucomas post-VR surgery, they should be initially, mild glaucomas should be managed medically with the anti-glaucoma medications and control the inflammation with steroids. And if there is a pupillary block, you may have to do peripheral iridectomy and always do multiple PIs. Actually, the photos are showing a patient following a PPV who came with severe inflammation and secondary glaucoma. We did PI, but it blocked and he came back again, and twice or thrice we had to do, and we then later did a surgical iridectomy. Glaucoma in pseudophakia is usually due to pre-existing glaucoma or a steroid response. Otherwise, if it is a very complicated surgery, it can result in secondary glaucoma. So always to prevent it, you can complete removal of the OVDs, and also in complicated surgeries, the excessive inflammation, they have to be managed with steroids. Then placing improperly sized and malpositioned ACIOL or PCIOL in sulcus, especially single piece IOLs, if you are placing in sulcus, their haptics may be sharp and it can rub on the iris pigment epithelium. It can lead to pigment dispersion and can lead to secondary glaucomas. And vitreous filling the anterior chamber, always do a proper anterior vitrectomy. So the aim in pseudophakic glaucomas is to lower the IOP to the high 10s or low 20s, never lower the tension to single digits. Anti-glaucoma medications and steroids have to be given, and in case of pupillary block you can do a PI. So aqueous misdirection is another very common condition that occurs after any ocular surgery, mainly seen if angle closure glaucoma is operated with trabeculectomy. So they have to be diagnosed. It has all the other causes of very shallow AC has to be excluded with B scan, and you have to proper diagnosis and immediate management with steroids, cycloplegics and hyperosmotics. And laser, always make sure that a PI is done. PI is patent, and otherwise you have to repeat it. And if not managed, then you can do a surgical management with iridectomy, hyaloid or sonloid. Thank you.
Thank you, madam, for the